Go ahead and start.
We're running?
Yeah.
So, Andrew, welcome again. Operation Moonshot, where do you want to start?
Well, first of all, thank you for doing this with me, because I found out about this and that it's in the UK, and I thought it was really important because, this is the first time we have actual evidence from the government directly about exactly what they're planning in the near future. And this was published in the British Medical Journal, which is where I found it. And Operation Moonshot is basically a plan, I think, from Boris Johnson to ramp up the COVID testing to a scale that's unimaginable. In fact, they want to, by 2021, test the entire population on a weekly basis. And there are many, many implications for this that I want to discuss with you. But I thought to really understand how this will affect the population, it would be really helpful to just clear up some things about the test, because especially the false positive rate, which a lot of people talk about, I realized that, people don't have a general conception of exactly what that means and how to apply it to the situation. So I thought I'd give a little bit of lesson on that and then apply it to Operation Moonshot to see, exactly how many people are going to be affected by this and in what way.
Okay.
So I'm going to share the screen here because I have a little slideshow, if I can find it here. There it is. And this will help guide us through my little lesson here. Okay. So the test itself, we'll talk a little bit about, is not really an accurate test, because when you develop a new diagnostic test for a medical condition, you have to do what's called a validation study. In other words, to determine if the test is valid. And to do that, you compare it against a gold standard. So in this case of a viral illness, the gold standard would be the presence of an actual viral particle. But they've never compared the PCR test to any gold standard. So there's no known error rate for this test at all. And so you can't calculate a false positive rate because you would need the error rate. So in other words, how many times does a person who really has a virus causing an illness have a positive test? And that has never been studied. So we have kind of a problem, and throughout this talk, I'm going to have to use some imaginary numbers because there are no real numbers. In other words, there's no firm diagnosis for COVID-19. There's not like an autopsy that you can do and you find a certain thing under the microscope and you say 100% sure that's COVID-19. They don't test anyone for the presence of virus particles other than like 2 or 3 people here and there in a published study, but it's never been done on a large scale. So we really don't know how many people have this disease, and we don't know what the error rate of the test is. So, but what I'm going to do is use government numbers from the UK government, because they put out estimates for all these things, and we'll just use their numbers to calculate what it would mean. So they put out this document that's referenced on the bottom from the Government Office for Science, where they said, based on these past studies of other viruses and other PCR tests, the error rate would range, the false positive rate would range from 0.8 to 4%. But they said that the median or the middle value is 2.3%. So they would say use that number basically as an estimate of the false positive rate. Now, most people think what false positive means is that the number of people who have a positive test, that 2.3% of those people, it's not actually positive. But that's not what it means. What it really means is, of all the people who don't actually have the disease, how many of those people would have a positive test? Okay, so if you have a relatively rare disease, like let's say it affects 1% of the population, okay, so 1 out of 100 people, that means that you have 99 people who, out of 100, who don't have the disease, and 2.3% of those people are going to give you a positive test, so approximately 2 people. So you can see when you have a disease even as rare as 1 in 100 with a 2.3% false positive rate, you're going to get 3 positive tests for every 100 people, but only one of them is going to actually have the disease. Okay, so this is the kind of analysis that I want to walk you through. So here are some of the government numbers that we're going to plug into this kind of mathematical formula here. And this comes from the ONS. And of course, this is also an estimate, but they have a protocol that is trusted by some other scientists who have written some articles. So I want to use their numbers. And what they said, the most recent week that I could find, September 13th to 19th, they said that 1 in 500 people had COVID-19, or 0.2% of the population. And in the summer, when it was less common than it is now, there was 1 in 2,000, or 0.05%. So we're going to use those two numbers to see what they would mean in like an example group of 10,000 people. So let's say we use the numbers from the fall, and we have a group of 10,000 volunteers who are going to take the test. Now, we know from the rate in the fall of 1 in 500 that there would be 20 of those people out of 10,000 who actually had the disease. So how many false positives would there be? So if we take the remaining people who don't have the disease out of the 10,000, which is 9,980, so almost the whole group, and 2.3 of that number is going to be 230 false positives. So we have only 20 people who really have the disease, but we have 250 who gave a positive test. So you could see that the headline could read there were 250 new cases, but really there are only 20. Now, if we take that a step further, because this is the question that most people want to ask, like their doctor. So if I have a positive test, what's the chance I really have the disease? So we can calculate that by taking the number of people with the actual disease and dividing it by the number of people who tested positive, which is 250. And you see that is only an 8% chance that if you have a positive in the fall that you actually have the disease. That's very, very low, okay? So this basically gives you an exaggeration factor of 12.5. So it exaggerates the number of cases by 12.5. Now, if we go back and do the same analysis for the summer, where it was less common, it was about 1/4 as prevalent, right? From 1 in 500 to 1 in 2,000, and use those numbers. Now, if you have a positive test, you only have a 2% chance of actually having the disease. And this is almost a 50-fold exaggeration. So you could see when they're reporting the testing results in the summer, which they used to cancel a lot of summer events and make policy decisions, they were exaggerating the number of real cases, if you believe that these numbers about the test are accurate, by almost 50 times. So you could see that could really scare the public and get them to go along with almost anything. And I'll tell you that there was one published paper that was later withdrawn where they also tried to estimate the false positive rate. And in that case, they estimated at 80%. So you could see that if we plugged 80% into this, it would be like a 500-fold increase in the number of false positives reported. So this is, since we don't know what the number actually is, we're just using these numbers, and I think these numbers vastly underestimate the real error rate of the test. So now I want to apply this to the plan for 2021, which is set out in Operation Moonshot. Okay, and so here's the British Medical Journal article that I mentioned earlier, and quite interesting, David, look at the publication date.
Yeah.
So, you know, is that a coincidence or not? I'm not sure, but nonetheless, so here we have the plan for Operation Moonshot is to ramp up the testing over the months in the fall, and by 2021, they're going to have what they call full rollout, which essentially amounts to 10 million tests each day. And in 1 week, that will cover the entire population of the UK, which is about 67, 68 million. Now, if we use the most recent numbers from September, where the prevalence is 1 in 500 people actually have this illness, that would amount to 20,000 out of 10 million people. Okay, so that's still a pretty small number. But if we look at how many false positives it would create, we can see that it will be almost 230,000 false positives. And so they would basically say out of 10 million each day, there would be 250,000 new cases, except only 20,000 would actually be real cases. Okay, so we're talking about 250,000 people, 230,000 people a day who are mislabeled as having this disease, but they're actually healthy. Okay, that's quite a lot of people. So this amounts to 1.5 million false positives each week, and 1 in 43 people. So each week in 2021, 1 out of every 43 people will be mislabeled as COVID positive when they actually are perfectly healthy. Now, they further outline in this plan that these testing results will be put into some kind of digital passport that we'll be required to have. And it'll keep weekly information about our testing results and probably other personal health information. And this will affect your ability to access a variety of services and activities in society. And this is laid out right in the plan. So this is the language right out of that publication. So attending medical appointments, being able to work, being able to access a venue for entertainment or other purposes. They specifically did mention a football stadium. And being able to travel. And they mentioned specifically to visit elderly relatives, which, you know, is the only semi-reasonable part of this. But they mentioned specifically flying, so that you will not be able to travel internationally unless you have the appropriate negative testing data. So, but we're talking about that the overwhelming majority of people who have a positive test are false positive. So all these people are going to be basically stuck in quarantine, and it's going to be a lot of people, right? 1.5 million people every week can't go to work. So
and the fines for not isolating when you have a positive test are already phenomenal.
Right. So, you know, you could see that it would get to a point where basically, you know, you leave your house and you can't actually do anything unless you have this passport and it says the right thing. And even if you have it, there's a good chance that within a year, you're going to be positive, whether you're sick or healthy or otherwise. So essentially, this operation really amounts to fascism.
100%. I see in the BMJ document, it actually talks about when you have a test, it gives people assurance, at least for a limited time, that they are unlikely to have the virus. And therefore, you're looking at constant testing of the population ongoing.
Absolutely. And, you know, I mean, it's one thing if someone comes in with the, you know, the appropriate symptoms of respiratory distress to the hospital or another healthcare setting, and you offer them a test, you know, that is, if you believe that the test is valid, that is an appropriate use of the test. Because you want to confirm that they don't have some other form of pneumonia and that it's this. And so if you trust the test, it can give you that information. And but even on the package label from the manufacturer for the PCR test, and I looked this at Roche's product, so ROCHE, one of the largest manufacturers of these PCR tests. And on there, it says that this is a test for the virus RNA, right? It says it right there in plain English. And it also says that you should use the results of this in conjunction with other clinical factors in order to make a diagnosis. So in other words, what they're saying is the test by itself is not enough to give you a diagnosis, even in someone who's symptomatic. So when you apply this to the healthy population, then you're going to get this huge error. Huge error. Because even if you get a false positive on someone who's sick, they still need treatment anyway. But if you label healthy people as sick and doing this, you know, 1.5 million people in the UK each week, it's going to I mean, first, obviously, for individual freedoms, it's a total travesty. But it's going to shut down the society. Like, it's going to bring productivity down really substantially, because, you know, that portion, you know, and it's more than 1% of the population, each week is going to be out of commission.
Yeah, I did have to smile, Andrew, when I saw this. It's talking about the need in Operation Moonshot to have a whole range of new ways of testing, because of the amount of people that they want to test. And it says that the PCR test will be the most accurate of them, and that these other tests will not be as accurate as the PCR test. So, I mean, you're in the world of madness, where you're going to have endless, quote, positive tests for people who are perfectly well and healthy. Well, that's going on now. But if they're bringing in tests that they are saying here are not as accurate as the PCR, then it's insanity we're looking at.
That's right, because you know, as I've explained, the PCR test is not even close to being accurate, right? So if you introduce even more error, then, you know, of course you have a big risk of labeling even more people incorrectly. So yeah, this is, you know, it's really crazy. And, you know, I thought this was so important because this is the actual government telling you exactly what their plan is, you know, straight out. And if you look carefully at the government documents about this test, you can see that they know it's not accurate, right? None of these diagnostic tests have been approved by any government agency, right? Like the FDA in the United States, who approves all diagnostic tests. They only received emergency use authorization. And in the guidance from the agencies on that, they basically, you know, discuss how they don't really know the accuracy of the test, because it would take years to do the testing, appropriately validating the accuracy of the test. And there's, you know, obviously time is short. I agree with that, because everything happened quickly, but nonetheless, that doesn't change the reality that you don't know anything about the accuracy of the test, because there hasn't been any tests, any studies done. Like, there's no studies published on the accuracy of this test. Whereas for all other diagnostic tests, they take, you know, years to develop, and they have all the studies. They get approval from the agency, which means that they've had to demonstrate that it's accurate. This has not been done at all. So the fact that they are tying so many important things to a test that's not accurate at all, you know, we could easily see who is sick. And those are the people that, if there really is contagion, which there's no evidence of, but those would be the people who would transmit it. Even, you know, experts like Dr. Fauci have spoken over and over again that people who are not sick are not going to keep a pandemic alive. The momentum can't come from them, because if there is transmission, the rate is so low that it's essentially unimportant.
I mean, we've reached the point where, you know, whether the virus actually exists or whether it doesn't has become, you know, close to an irrelevant debate, in the sense that the numbers, the official numbers, are so low, and the ratios of infection to fatality so unbelievably low, that even if you accept it exists, I do not, then what is being done in its name bears no resemblance to any kind of rational reality. And therefore, obviously, it's being done for another reason, which is nothing to do with protecting people's health.